So, good afternoon, everyone, and welcome to today's CPD on the management approach of hypertension in metabolic syndrome. Today's CPD is actually an international broadcast, and we'll be joining our speakers live in France, where they'll be taking us through this very intricate subject. So it's actually going to evolve in two parts. The first part will be by Professor Aleksander PREJBISZ, who is going to walk us through a typical case study of hypertension in a patient with obesity, which is a clear case of metabolic syndrome. And then we would have the second part by Prof. Stefano TADDEI, who is also a medical doctor with a subspecialty in clinical pharmacology. And he is actually going to explore the therapeutic options you have for these kinds of patients. And most importantly, which single pill combination is best suited when managing your hypertensive patients with metabolic syndrome. Now, before the live broadcast begins, which would actually be at 4 p.m., I would entreat you to note all questions in the comments section, and please do well to accompany all questions with a question mark. And also, there will be a brief presentation after the live broadcast, so we would kindly plead with you to not log out and follow this brief presentation with us. And then last but not the least, we all know that this is an accredited CPD, so to be able to earn your CPD points, you need to have completed your pre and post test to be eligible for your CPD points. So would just hold on and wait whilst we are tuned into the live broadcast in France. Thank you.
Hello, my name is Aleksander PREJBISZ, and my pleasure is to invite you for a case presentation and discussion, how to treat hypertension in probably most common clinical condition that you encounter in your daily practice. Middle-aged patient with some obesity, metabolic disorders, and hypertension. We should treat those patients properly, since those patients are of high cardiovascular risk. I invite you cordially to join us and to see the case and discuss the treatment of this patient with us. Thank you very much.
Hello, everyone. So, we are currently experiencing some technical difficulties with France. So, if you could kindly bear with us whilst we resolve this, but the CPD would start any moment soon. So, please stay put and bear with us as we resolve these technical issues. Thank you.
This is the questions we are going to address today, thanks to the expertise of Stefano TADDEI. Hello, Professor.
Hello, how are you?
I'm fine, thank you. You're a doctor of medicine and surgery, specialized in clinical pharmacology, and you work in the Department of Experimental Medicine in Pisa, Italy. With us also, we have Aleksander PREJBISZ. Hello, Professor.
Hello. Good
Hello.
afternoon.
Thank you. Good afternoon. Thank you for being with us. You have a PhD in cardiology and you specialize in internal medicine. You are a professor at the National Institute of Cardiology in Warsaw, Poland. So thank you to the two of you for being with us today. It is estimated that 1.28 billion people worldwide between the ages of 30 and 79 have hypertension, and most of them, 2/3, live in low and middle income countries. Less than half of adults with hypertension are diagnosed and receive treatment. Hypertension is controlled in about 1 in 5 adults, and hypertension is one of the leading causes of premature death worldwide. People suffering from diabetes, obesity, or metabolic syndrome are more likely, as you know, to be concerned by high blood pressure. Treatments for high blood pressure must be taken throughout life and on a very regular basis. And this is all the more important as you know, again, hypertension is a silent disease, which means that patients who suffer from it do not always feel the symptoms. Let's remember that an estimated 46% of adults with hypertension are unaware of it. So this is why compliance with treatment remains essential to ensure its effectiveness. Indeed, it's very, very, very important to control blood pressure in order to prevent end-stage organ damage and cardiovascular events. So this webinar is going to last more or less 45 minutes, and after that, you'll be able to interact with our speakers. So please feel free to send in your questions throughout the platform, and you don't have to wait until the very end to do so. You can send your questions whenever you want during the presentation. Which dual single pill combination in the routine management of hypertensive patients with metabolic profiles in 2022? To answer these questions, we are going to discuss the case of one of your patients. This patient is a 58-year-old male with metabolic profile, and he suffers from excess weight. Let's start with you, Professor PREJBISZ. What are his symptoms and his current treatments?
Thank you very much and welcome again. Thank you also very much for inviting me and having the opportunity to share with you this interesting case. But this is a case which is not a case of very sophisticated patient, but a patient that we have in our everyday practice. We will meet the patient like this in our outpatient clinic today, tomorrow, and we have to find out and think what is the best treatment based on pathophysiological traits, but also on solid cardiovascular outcome data. What should we choose in those patients to treat them better and reduce their cardiovascular risk? So, coming to this patient, this is 58 years old male patient with hypertension of a few years duration, with some metabolic abnormalities, which would be detailed later. And he also reports now no complaints. This is very important. This is asymptomatic patient, but already with the disease. This patient, when asked about his attitude towards hypertensive treatment, he said that he admits that sometimes he skips evening doses of medication. This is very important clue for us, also for the choice of his future therapy.
So, sorry, go on.
But first, start and look at his blood pressure values. In order to well control his blood pressure, we should check if his blood pressure is uncontrolled and what should we do when we should react. So current treatment of this patient is valsartan, 80 milligrams, 1 tablet in the morning and 1 tablet in the evening. This is this tablet in the evening, which is mostly skipped by this patient. So it looks like at his home blood pressure measurement, these are the perfect ones. The perfect ones, not in terms of the level, but in terms of the scrutiny and keeping with the guidelines. We have 7 days. Each day there are twice 2 measurements in the morning and 2 measurements in the evening. We skip the first day and we look at the days from the 2nd to the 7th, and we see that all his blood pressure values are high. So we have uncontrolled hypertension in this patient, very good proof from his home blood pressure readings. To confirm that, this next slide, we performed in this patient ABPM monitoring, but you can see that it only confirmed what we have from the home blood pressure measurement. This is very also important clue that when we have a patient, if the patient sticks to the strict rules of measuring twice in the morning before the medication and twice in the evening if he's taking medications in the evening, also before the medication, before the breakfast or before the supper, we have the best recording of his blood pressure over several days at home. So let's summarize, please, next slide, his blood pressure levels. And can we move the slide a little bit more? We see that all his blood pressure levels are above the limits. His office blood pressure, his home blood pressure measurements, and also ambulatory blood pressure measurements. You should be aware that as we have the lower now targets of blood pressure, this is also valid to the morning measurement, to the measurements at home, which should be also under 130/80.
So Professor PREJBISZ has been telling us about some measurements of blood pressure for this 58 years old patient. Professor TADDEI, how can we control blood pressure?
This is your question is a crucial point in the treatment of patients at high cardiovascular risk. Next slide, please. Because we speak about many health problems around the world, including COVID pandemic, including cancer, including rare neurological diseases. But if you look at the results, at the data from WHO, you see that the most common causes of death in the world are the cardiovascular risk factor. At the end, those are the main problem for which people die. And among the different cardiovascular risk factors, hypertension is the first one, is the most important one. So that is the reason why it's important to take care of hypertension and to try to improve our way of treatment of hypertensive patients. The next slide. And hypertension is so important that if you see patients with different cardiovascular risk, those are the results from the Framingham study, and you see and you analyze patients with different cardiovascular risk factors, including smoking, hypercholesterolemia, diabetes, old age, and you see how much is the impact of the income if blood pressure reduction is effective, because we can measure target organ damage and to see if there is the reduction or there is the prevention, and also have a metabolic protection. But at the end, we have to reduce cardiovascular events. And while it's easy to measure blood pressure normalization, it's not easy, it's not possible to measure reduction cardiovascular events. The only possibility I have is to look at scientific literature and to look at controlled clinical trial and to use those drugs who have a clear demonstration of effectiveness in controlled clinical trial. I have to anticipate that all antihypertensive drugs can lower blood pressure values, but the effectiveness on hard endpoints is very, very different from drug classes to other drug classes. Next slide, please. It's clear, if I lower blood pressure values, I improve the prognosis, because in this meta-analysis, a very famous one, this is the evidence that if I reduce 10 millimeter of mercury of systolic blood pressure and 5 millimeter of mercury of diastolic blood pressure, I can reduce coronary artery disease and strokes. Next slide. But what is more important is the demonstration in this other meta-analysis that greater is not just 10 millimeter of systolic blood pressure or 5 millimeter of diastolic blood pressure, but more I reduce blood pressure values, the lower lung of the column, patients with a very high blood pressure, greater than 160, and the treatment lower blood pressure to up to 120, 124, you can see a progressive reduction in cardiovascular disease and in total mortality. So I need to lower blood pressure at the best to my possibilities. Next slide. As requested by the guideline, but please take into consideration that target values are lower than 130 millimeter of mercury for systolic blood pressure, but not lower than 120 millimeter of mercury in patients with hypertension or hypertension plus diabetes, CKD, coronary artery disease, cerebrovascular disease. For diastolic blood pressure values, you have to lower to 80, but not greater than lower than 70 millimeter of mercury. Next slide.
Yeah, next slide is for you, Professor PREJBISZ, because I suggest that we now take a closer look at the patient in order to find hints.
Thank you very much. Indeed, we have to look at the patient to find some hints how to tailor the antihypertensive treatment in this patient. First of all, this is a patient with obesity. And you can see that this is not only the obesity measured by BMI, but also abdominal obesity measured by waist circumference, which is high, 110 centimeters. On the physical examination, apart from that, there are no other abnormalities. We should look also on his lifestyle. This is a very important part of the medical examination, and the lifestyle of this patient is bad. Of course, he never smoked, but he drinks too much alcohol. We must remember that current ESC prevention guidelines advise that the amount of the alcohol per week should not exceed 100 grams. Of course, we as a doctor should advise our patient that every amount of alcohol is related with mortality, increased mortality. So this patient should at least limit his intake of alcohol under 100 grams, but also drink as low as possible. His dietary salt intake is high, 10 grams per day. This is exceeding what should be his aim, which is 5 to 6 grams per day. But also he drinks coffee. Coffee is very good for your health. There is influence on the reduction of the cardiovascular death, of the reduction of the risk of the diabetes. But please notice that this patient is drinking coffee with milk. Of course, you can drink 1 cappuccino per day before the noon, but the milk in the cappuccino is probably not good, not only because of calories, but all the good substances that are in coffee are not valid when you are adding milk to your coffee. Of course, there is a dietary Coke. This is a resolution. He should not drink caffeine, which is not in coffee. So I think that for his blood pressure, he should reduce this dietary Coke. Exercise, he does not perform non-work physical activity. Of course, he should exercise as much as possible. Eating habits, not healthy. And looking at his laboratory exams, we can see that there are some others components of the metabolic syndrome. We have the obesity, abdominal obesity, which is the core of the metabolic syndrome. We have hypertension, which is one part of the metabolic syndrome. And we have also 2 major aspects of metabolic syndrome. Glucose metabolism abnormalities. His fasting glucose is over 100 with glycolated hemoglobin of 5.9, which is in the range of prediabetes. And you should look at his lipids. Cholesterol LDL is 125, but his non-HDL cholesterol, which is a best atherosclerotic related part of the metabolic abnormalities and now an emerging risk factor, especially in patients with metabolic abnormalities, is also high of 167. But we should notice also that on this very early examination, we notice his hypertension-mediated organ damage. Look, his albumin to creatine ratio is almost 40 milligrams per gram. So this would be in the range of microalbuminuria. And also on ECG, we have left ventricular hypertrophy. So this is a patient with established hypertension-mediated organ damage. But let's look at his echocardiography. And I think that probably you guessed that we confirm findings of ECG with concentric left ventricular hypertrophy. And also, this next slide, we looked at his systolic function. Ejection fraction is normal, but you can see that the global longitudinal strain is impaired. And also global longitudinal strain is now emerging as a risk factor for cardiovascular events. So we can say that this is a patient with a normal ejection fraction by evaluation of ejection fraction, normal systolic function, but he has already a subclinical systolic dysfunction, which is related to higher cardiovascular risk. Please, next slide. And we have also to remember that heart failure with preserved ejection fraction is also the part of the metabolic abnormalities and the consequences of obesity accompanied by high blood pressure values. So in this patient, we are not surprised that he has already diastolic dysfunction, which is related to his hypertension and obesity. So to summarize, this is a 58-year-old male patient with sedentary lifestyle, increased sodium intake, abdominal obesity, impaired fasting glucose, increased non-HDL cholesterol, uncontrolled blood pressure, slightly increased albuminuria, and left ventricular hypertrophy. So, please, next slide. We have a patient with high cardiovascular risk and also a patient with metabolic syndrome, and urgently we need to improve his cardiovascular risk.
Professor TADDEI, Professor PREJBISZ explained to us that this patient doesn't have such good habits as far as his lifestyle is concerned. Can the potential pathogenesis of hypertension help us with therapy?
Absolutely, because again, I come back to the concept that we measure blood pressure, but measure blood pressure is just just an indicator, just a marker. Blood pressure values are the determinants of blood pressure values are different, and they play different role according to the phenotype characteristic of the patients. In these patients, the main phenotype is related to obesity, and obesity is related to obesity. There is the increase in the renin-angiotensin system activity. There is the presence of insulin resistance. There is a salt retention. So altogether, this pathogenetic factor contribute to the vascular dysfunction, which are typical of hypertension, including inflammation, including arterial dysfunction, atherosclerosis, or structural changes such as vascular fibrosis, arterial remodeling, leading to alteration in the large vessel in the microcirculation, and the final consequence is cardiovascular disease. Next slide, please. And what is important to remind is that in the middle of this pathogenetic cascade, angiotensin II plays a role as a main actor, because angiotensin II is a really bad guy that can evoke oxidative stress, inflammation, endothelial dysfunction, tissue remodeling, according to different activity that I'm not going to discuss now, but is very important because, next slide, you can see that in the cascade that start from risk factors and it arrives to cardiovascular event and increased mortality, there is a series of pathway, important pathway mechanism, including endothelial injury or dysfunction, inflammation, and all the aspects leading to atheroma and to increase the thrombosis. So this is a very complex mechanism, but that basically responds to common factor, inflammation, oxidative stress, decreased endothelial function. Next slide, please. And when we speak about the renin-angiotensin system, we can really appreciate the difference between the classical concept and the real biological concept. Okay, we think to the renin-angiotensin system as a circulating system devoted to regulation blood pressure values. This is true, but it's only the 10% of the system. In the biological reality, most of the renin-angiotensin system is a tissue system. 90% of the system is inside the vessel wall, and it is related to long-term effects and tissue homeostasis. And what is relevant of this tissue system? The tissue system is not only linked to the ability of ACE to convert angiotensin 1 into angiotensin 2 and angiotensin 2 to stimulate AAT receptor, but also there is a strong component related to the ability of ACE to induce bradykinin degradation. And bradykinin is an important substance, it's an autocoid, and has very, very active beneficial effects on vessel. It's a substance related to vascular protection. Thus, there is a complex role related to the ACE activity inside the vessel wall. Next slide. And this is clearly explained in this balance because I have the bad guy, angiotensin II, and the bad guy that causes vascular alteration, and I have the good guy, which is the nitric oxide related to bradykinin, related to the increased availability of bradykinin that has several mechanisms inducing vascular protection. And this interplay between the two substances, and this is one of the most important mechanisms evoking cardiovascular disease. Next slide, please. And even when we speak about the ability of ACE to induce bradykinin degradation, you have to consider that there is the possibility to block this effect by ACE inhibitor. But the subunit through which ACE inhibitor block the conversion of angiotensin 1 into angiotensin 2 is different from the subunit related to bradykinin degradation. So what does it mean? That ACE inhibitor have a different activity on bradykinin depending on the affinity of tissue ACE. Next slide. This is clearly a demonstration, this elegant experiment. This is an in vitro experiment, of course, demonstrating that the perindopril, the active substance from perindopril, the activity of perindopril is much greater than other ACE inhibitors in determining increased bradykinin availability. So perindopril is the most potent ACE inhibitor in determining increase in endogenous bradykinin. Next slide. And you can see what this kind of mechanism can determine at the level of apoptosis. Apoptosis is an important mechanism related to vascular deterioration because it's the planned death, the programmed death of endothelial cells, and you can observe that perindopril is the most potent ACE inhibitor which can block the induction of apoptosis. Okay, this is also another in vitro experiment and in humans. Next slide, we have evidence in humans because this is a sub-study of Pertinent. Pertinent is a subgroup of patients from the Europa program, and you can observe the patients participating in the Europa study. The authors measured endothelial apoptosis. You can see the baseline, and you can see that after 1 year of treatment, placebo is not placebo, standard treatment, and perindopril, you can observe that only perindopril was able to reduce apoptosis. And this next slide. This is confirmed in this other study in patients with previous acute myocardial infarction. But what is really relevant from this study is the comparison with valsartan, because you can say that perindopril can reduce apoptosis, but not valsartan. Why? It's very simple, because valsartan is an ARB, and ARB don't affect bradykinin. They have not the positive effect of bradykinin. So this is not a mechanism related to angiotensin 2, but is a mechanism related to increase bradykinin concentration. Next slide. And a similar result we had in hypertensive patients. We measured several years ago brachial artery endothelial-dependent vasodilation by flow-mediated dilation. You can observe the green bar normotensive subject. This is the endothelium-dependent vasodilation as compared to hypertensive patients. You can see that it's reduced. We studied in parallel group different antihypertensive drugs, ACE inhibitors, calcium antagonists, beta blocks, and ARB, and you can observe that only perindopril was able to improve endothelium-dependent vasodilation, an effect not exerted by telmisartan, because again there is no effect on bradykinin. So next slide.
Yeah, next slide. We'd like to know now if your patient is feeling better. So I suggest you explain to us if your actions have helped the patient, Professor PREJBISZ.
Our patient feels good because he had no complaint, and his unhealthy lifestyle was probably very good for him. But what first we advise our patient, we discuss with him that he is obese, and also that he should change his lifestyle in order to reduce his cardiovascular risk. And as a core part of his lifestyle modification, he should reduce body weight, also reduce salt intake by cutting on processed foods and also dosages of salt, increase his physical activity as much as possible, and reduce alcohol consumption. But please remember that this is also very important, that the goal in lifestyle modification should be not unachievable by patients. So we should not tell the patient that he should or she should reduce body weight by 20 kilograms, but by 3-5 kilograms in a few months. So this would be achieved by the patient. If the patient achieved this goal, we should congratulate the patient and make the other goal. So this is very important to be supportive for the patient in achieving his lifestyle modification goals. Please, next slide. Also, we modified his pharmacological treatment. As you remember, this patient does not like taking drugs in the evening, and also he needs a more potent drug for his blood pressure. So we choose to withdraw his valsartan treatment and introduce to him treatment with perindopril and indapamide. We choose dosages of 10 milligrams of perindopril and 2.5 milligrams of indapamide, and we also used a single pill combination to reduce number of pills and to have a better adherence by using a fixed dose combination. Also, we added to the treatment of the patient atorvastatin, which is a statin to reduce his high cholesterol level. So you see the long road of this patient leading us to home blood pressure measurements after 6 months of his new treatment. Can we see the next slide? And we see his perfect blood pressure measurements. Now they are not only taken perfectly, but because he took this through 7 days, twice in the morning, twice in the evening, one by one, one after another, but also he has a very good blood pressure control. Of course, there might be some high blood pressure levels a little bit above level, but majority, and I would say almost all his blood pressure readings are below the limits. Please, next slide. And we see his blood pressure levels. Please, next one. And all the indices of blood pressure control, home blood pressure measurement, ambulatory blood pressure, and office blood pressure are under control, below the target values. And we can say that now, because we introduced to the patient potent drugs with high cardiovascular reduction action and good blood pressure control over 24 hours, what we see both on ABPM, but also in the morning readings on his home blood pressure measurements, because these morning readings are very essential. They are taken in the morning before the patient takes the next dosage of the drug. So we see if the drugs works 24 hours. So you saw that on his blood pressure readings from home, every morning reading was good. So the patient was the patient had a 24-hour duration of drugs which he took. And also, this is a very good patient, very motivated patient. He wants to change his life, and his willingness is translated into body mass reduction of 5 kilograms and also improvement in his glucose metabolism and also reduction in lipid profile, which is also supported by the use of statin. But also look, his albumin to creatine ratio decreased because of the action of kidney protection by the drug that we choose for his treatment, that means perindopril indapamide in the fixed dose combination.
So the questions we would like to ask you now, Professor TADDEI, is the following: should we prioritize blood pressure control or cardiovascular risk reduction?
And this is an important point, because people is convinced that if blood pressure is controlled, you have obtained the goal of your treatment? No, because basically you need to reduce cardiovascular event and not just the mere blood pressure control. So how to address, as a consequence, how to address treatment in these patients? If I look at the guidelines suggested to start with a RAS blocker combined with a calcium antagonist or a diuretic, possibly using a single pill to increase adherence to pharmacological treatment. Next slide, okay. But so I can agree to start with the combination of RAS blockers plus a diuretic or calcium antagonist. Why? As correctly chosen by Professor PREJBISZ, we can decide to use the combination of ACE inhibitors and a diuretic. Next slide. Because what is the rationale, the drug blocking the renin-angiotensin system and diuretic? Next slide, okay, next slide. Because first of all, I had to take care of the increase in the renin-angiotensin system activity plus insulin resistance. And this can be addressed, of course, next slide, by using RAS blockers. But next slide. Is it the same to use an ACE inhibitor or NRB? On the other hand, the guideline just say use a RAS blocker, and not they say use hypertension, use an ACE inhibitor or an ARB according to the situation, so on. But if I come back to the mechanism of action of drugs blocking the renin-angiotensin system, I can see that why ACE inhibitor have two important mechanism, suppression of angiotensin II and upregulation bradykinin. ARBs, they block AT1 receptor that could be considered a good opportunity, but by blockade of the T1 receptor, they upregulate angiotensin II because of the feedback mechanism, and there is no impact on bradykinin. We have no activity on the effect of bradykinin. Bradykinin is very important for coronary circulation. And in the clinical practice, I can see from controlled clinical trial, this is a meta-analysis, that ACE inhibitors can reduce coronary artery disease. Why? ARBs have no effect on coronary artery disease. Usually when I presented this slide that is from a very distinguished meta-analysis, I see that how it is possible, how the ARBs are very good drug, how is it possible? It is possible, next slide, because there is no one controlled the clinical trial who has demonstrated that as ARBs can reduce coronary artery disease. There is no evidence in no one trial ARBs were able to reduce coronary, the specific endpoint. Next slide. Some example, BAIDOO, valsartan versus amlodipine. Amlodipine was superior to valsartan in reducing coronary artery disease. At the end, that was a study performed for renal protection, but looking at cardiovascular events, amlodipine was superior to irbesartan to reduce coronary artery disease. And please read the roadmap and the astonishing result of roadmap that are not considered because, next slide, the study performed in patients with diabetes. It was designed to demonstrate that olmesartan can delay a few weeks onset of macroalbuminuria. But, next slide, in the same patients, olmesartan increased cardiovascular mortality. And this is not the unique finding with olmesartan, because in a previous study, the Orient study performed in a smaller sample, we had a similar result that olmesartan increases cardiovascular mortality. And if you look at the paper published in European Journal of Medicine, the conclusions raised by the author, not by Stefano TADDEI, you can read that the higher rate of fatal cardiovascular events with olmesartan among patients with pre-existing coronary heart disease is of concern. So you can really see the difference between blood pressure normalization, surrogate endpoints such as macroalbuminuria, and the reduction in cardiovascular events. This must be proven, directly proven. Another important aspect is total mortality. Total mortality is the most potent endpoint, and again, while ACE inhibitors can reduce total mortality, ARBs have no effect on the most important hard endpoint, and this is seen in patients with hypertension, in patients with diabetes, in patients with coronary artery disease, and in high-risk patients. Next slide. And now, finally, guidelines start to say that ACE inhibitor should be considered first-line drugs to block the renin-angiotensin system, and ARB can be considered only in presence of absence of tolerability of ACE inhibitor. This is stated by NICE hypertension guidelines, ESC guidelines from chronic coronary syndromes, ESC guidelines for diabetes, pre-diabetes, and cardiovascular disease, and ESC guidelines for heart failure. More recent guidelines start to state that ACE inhibitors are the first choice drugs. Next slide. Which ACE inhibitor? The evidence is not similar with all ACE inhibitors. So first of all, perindopril is without doubt the ACE inhibitor with the most evidence obtained of beneficial effect obtained in controlled clinical trial. I told you before, this is the only, this is the most important aspect in the clinical practice. You have to choose drugs whose effectiveness is demonstrated in controlled clinical trial, and for perindopril, this is the highest level of proof. But even if we go to analyze into the details the meta-analysis that I quoted before, demonstrating that ACE inhibitors can reduce cardiovascular total mortality, while ARBs are not effective, you can observe that the beneficial effect of ACE inhibitor is mainly driven by three studies, ASCOT, ADVANCE, and IVET, that are all studies based on perindopril. Next slide. Coming on the second aspect, why diuretic, we decided to combine a diuretic and not a calcium antagonist with the ACE inhibitor. Next slide. Next slide. Because our patients has other two clinical characteristics, obesity and soil retention. And in those conditions, we need to use a diuretic. If you want to reduce blood pressure values in a patient with obesity, and obesity is always associated to soil retention, you must use a diuretic, but you have to choose the right one. Next slide. Next slide. Because diuretics are not the same. We are used to consider as the same. And you can observe that, for instance, hydrochlorothiazide is a typical diuretic with a natriuretic effect. Indapamide, in addition to the natriuretic effect, there is the downregulation of the sympathetic nervous system, an effect similar to calcium antagonist, increase the prostaglandins, and a very potent antioxidant effect. Next slide. And this is the reason why a recent guideline state that we have to use first thiazide-like diuretics, indapamide and chlortalidone, but NICE guidelines and the American Diabetes Society guideline quote specifically indapamide to be used in patients with hypertension and in patients with diabetes. Next slide, please. Why? Because indapamide is the only diuretic which has evidence of effectiveness on target organ damage. For instance, you can see from this table, can improve neutrophil function, can reduce pathway velocity, so can improve arterial stiffness, can reduce left ventricular hypertrophy, can reduce macroalbuminuria and albuminuria. But what is more important in the slide, as a very, very impressive demonstration of effectiveness in controlled clinical trial, IVET, Advance, Progress, and PATH. So there is a strong demonstration that this diuretic can reduce cardiovascular events. Next slide. And I like to quote this meta-analysis because not just to make you see the result of meta-analysis, but because, next slide, after this article, this meta-analysis, there was the commentary of Norman Kaplan, one of the most eminent scientists in hypertension, that his conclusion was that indapamide is it the better diuretic for hypertension. Next slide, please. So this is the rationale to use perindopril together with indapamide in the treatment of patients with the metabolic alteration. But I have a demonstration that this combination is really effective. Next slide. Yes, I have, because of advanced trial performed in patients with diabetes and pre-diabetes. In the slide next, you can observe this is the reduction of perindopril indapamide as compared to control that, as always in those studies, is now the slide before, please. Come back, please. Okay, control treatment is a standard treatment. Next slide. And it's clear that the combination of perindopril plus indapamide can reduce mortality in patients with diabetes. Not only this effect, next one, next slide, but you can observe protection is linked also to renal protection, because you can observe that perindopril indapamide can reduce total renal events, new or worsening of nephropathy, and new macroalbuminuria. So demonstrating that renal protection is not only characteristics of ARB, but it's also shared by ACE inhibitor. But what is more important, next slide, if I look at the results of trial performed in diabetes, you can observe that ARBs are very effective in renal protection. But if you look at cardiovascular mortality, and you have to consider that the patients with renal disease die for cardiovascular disease, you can observe that the only study was demonstrating the effectiveness of treatment in reduced cardiovascular mortality and total mortality was Advance. Next slide. You can observe that was many drugs can assure renal protection, but only one compound, which is an inhibitor in the perindopril, can reduce cardiovascular event and total mortality. And again, the problem is okay to save the kidney, but it's more and more important to reduce cardiovascular events. Next slide. So my conclusions, ACE inhibitors are the first-line drugs since they are superior to ARBs in reduction of cardiovascular outcomes and total mortality. Among ACE inhibitors, perindoprine has the highest level of proof that thiazide-like diuretic indapamide should be preferred to hydrochlorothiazide. In hypertensive patients, treatment with the combination of perindoprine plus indapamide has the scientific evidence demonstrating reduction in total and cardiovascular mortality. And really, I stress the final concept because if the choice of antihypertensive treatment is driven by the scientific literature, this is not doubt that perindoprine is the compound with the best positive documentation for the treatment of patients with hypertension. And thank you very much for your attention.
And thank you to the two of you, because your presentation was very clear and was very interesting. I think it enabled us to better understand the stakes of this disease and above all the way to help patients. So it's now time for questions from our audience. Please, dear doctors, feel free to send in your questions throughout the platforms, your questions for our two speakers. And we did receive this first question for you, Professor PREJBISZ. Can you please elaborate more on the three main pathophysiological common characteristics to address when treating hypertensive patients with metabolic profiles, such as weight excess and metabolic syndrome?
Thank you very much for this question, because the pathophysiology of hypertension in obese and metabolic syndrome patients is very important, because it allows us to adjust the antihypertensive treatment according to the pathophysiology. Unfortunately, this is also a very complex pathophysiology, but I would like to stress the traits that are very important. First of all, there is the kidney and the sodium retention and the volume expansion. So this is the best way to use a diuretic, because we need to help the patient to excrete more sodium and to reduce volume. So this was also the reason why we choose indapamide in this patient. But also, there is a renin-angiotensin system, which is activated very, very high in patients with obesity and metabolic syndrome. So we have to adjust the treatment to inhibit the renin-angiotensin system, and also to have the possibility to act with cardioprotection and kidney protection by inhibiting the renin-angiotensin system in obese patients with metabolic syndrome.
Thank you for your answer. The next question is for you, Professor TADDEI. In your clinical experience, among the different dual single pill combinations available, which treatment has allowed you to achieve blood pressure targets with a long-term control for hypertensive patients with weight excess?
And this is a good point, because, of course, I had the possibility to choose between two very logical and very effective combinations: NAC inhibitors plus a calcium antagonist, or NAC inhibitors plus a diuretic. So depending on the different characteristics of the patients, I can choose between the two kind of combination, both available in single pill. So there is not basically a problem in the management of the treatment. In this case, in the presence of a patient of weight excess, I have no doubt to use the combination with the diuretic, because as I told before, and as is also introduced by Professor PREJBISZ, patients with weight excess are characterized by sodium retention. So we need a drug with a very potent natriuretic effect. Calcium antagonists have a certain natriuretic effect, but not so potent as the diuretics. This is another problem. In obese patients, there are, especially women, they can have more easy ankylodema. Of course, ankylodema is reduced by the presence of the ACE inhibitor combined with the calcium antagonist. But sometimes we don't, is a side effect that we want to avoid. But in any case, from the physiopathological point of view, it's more rational to combine the ACE inhibitors with an effective diuretic such as indapamide in presence of patients with weight excess. There is no other way to lower blood pressure values in patients with those characteristics.
Okay, so let's take the case of a hypertensive patient going for bariatric surgery, Professor PREJBISZ. Which antihypertensive agent will be more effective to control high blood pressure?
If we take patients with high obesity, we should use probably all the antihypertensive drugs, because the more obese the patient is, the high blood pressure is. So I would even say that this patient is not with morbid obesity that is related to the bariatric surgery. It's not only the patient in which the drugs don't work, but the patient needs a lot of drugs. But also, we should skip the basic rules, and we should use, as in our patient, a renin-angiotensin system inhibitor, and ACE inhibitors here are the very best choice. And also the indapamide as a diuretic with this dosage of 2.5 milligrams. This is also the drug that we should use in those patients. And also then we should escalate the treatment with calcium antagonists, beta blocker, and also aldosterone antagonists.
Thank you very much. Professor TADDEI, outside ACE inhibitors and ARBs, what other therapeutic class or molecule demonstrated in order to reduce the rate of microalbuminuria?
Basically, RAS blockers, ACE inhibitors, and ARB are the most potent drugs which can block macroalbuminuria because of the mechanism of action. They are very strong in reducing intraglomerular pressure because the effect on the efferent arteriole. So no other antihypertensive drug have the same efficacy. Of course, there is an effect which is shared by all other antihypertensive drugs, which is related to blood pressure reduction. Blood pressure reduction per se can reduce intraglomerular filtration rate, so can be protective. I forgot that ACE inhibitors can have also an effect on mesangial cell. The unique other compound who has a study demonstrating the reduction in microalbuminuria and albuminuria, as I quoted before, is indapamide. Indapamide because is a diuretic, which is not totally diuretic, as other effect as we discussed before, so it has demonstrated an efficacy even on macroalbuminuria, so this explains the beneficial effect of the combination in advance. Finally, I can remind you that a new drug class, SGLT2 inhibitors, anti-diabetic drugs that now have a role in heart failure, they have shown to be a protective effect on renal function.
Professor PREJBISZ, the recent ADA guidelines highlighted the unique life savings benefits of perindopril indapamide FDC. What is your opinion regarding these guidelines and their implication in the management of hypertensive patients with weight excess?
I think this is a very wise statement, because in patients with obesity and metabolic abnormalities or glucose metabolism abnormalities, we have to choose drugs that first reduce cardiovascular risk and have the solid data. This was summarized by Professor TADDEI, that those combination of perindopril indapamide reduces the cardiovascular risk, but also we should look on the influence of the drugs on the metabolic profile. And sometimes we are afraid of using a diuretic in those patients because we think that it might worsen the metabolic profile, but we should look at the studies with indapamide, which show that this is a drug which is metabolically neutral, and in patients with metabolic abnormalities like patients with diabetes, it was proven that the combination of perindopril with indapamide is life-saving and reduces cardiovascular risk without worsening metabolic profile or even improving it, which was proven for the ACE inhibitors.
Thank you very much. We have one more question for you, Professor TADDEI, the last question, because we're running short of time. So can you please explain how perindopril and indapamide can have a synergistic action on the endothelium protection?
I just quoted before that basically the difference is in indapamide because perindopril is an ACE inhibitor. ACE inhibitors are very potent on endothelial protection, and especially perindopril because of its potency in reducing bradykinin degradation. But indapamide is the only diuretic which is not totally diuretic, so it can I showed you before that has antioxidant properties, and the ability of drugs to block oxidative stress is the main mechanism leading to endothelial protection. So if we combine two drugs with the synergistic effect against the mechanism leading to endothelial dysfunction, from one side, increasing bradykinin concentration, so stimulating nitric oxide activity, and from the other side, reducing oxidative stress, so reducing nitric oxide breakdown, we can obtain a special treatment for endothelial dysfunction.
Thank you very much. We are now reaching to the end of this webinar. I would like to thank the two of you for your presentation, but also to the answers to our audience. I'd like to thank, of course, all the doctors connected who followed us today. And of course, I'd like to thank also all the people here in Servier who have been working hard in order to make this live webinar possible. Well, have a good day, and we hope to see you soon. Bye-bye.
Hello, everyone. So thank you so much for taking part in, the first part on the disease condition, and then the management protocol for these patients. As you would clearly notice, there was much emphasis on the combination, on a single pill combination, because it was obvious that this patient wasn't compliant when it comes to taking multiple pills. And then there was, the molecules that were highlighted were perindopril and indapamide. And for that, we currently have that on our market as Coversol Plus. So Coversol Plus is a combination, a fixed dose combination of perindopril arginine and indapamide. And we have it available as in two strengths, so 5 1.25 and then 10 2.5. Now, we at Servier say Coversol Plus is the winning strategy for your hypertensive patients with metabolic syndrome. And we could see clearly from the previous discussion by the professors that this molecule is very, very beneficial in managing the hypertensive patients with metabolic syndrome. So just to throw a little more light on what was previously discussed, how the pathophysiology of these patients, what it is to have hypertension in metabolic syndrome, and how the individual molecules address the pathophysiology. So if you would remember correctly, Prof. Stefano mentioned an activation of the RAS. And then we also have the characteristic insulin resistance and also sodium retention. So mostly in these patients, what is really characteristic here is the sodium retention. And this is actually as a result of two pathways. The first one has to do with the RAS activation. And we all know the RAS activation. So angiotensin 1 to angiotensin 2, which would stimulate the secretion of aldosterone, which would eventually result in sodium retention. Now, there's also another contributory factor to sodium retention, and that is hyperinsulinemia, which would eventually result from the insulin resistance that I pointed out earlier. So these two contributory factors, how does Coversol Plus or this combination of perindopril and indapamide address that? So perindopril as an ACE inhibitor would definitely block the RAS activation, okay, and thus prevents that pathway. So perindopril being the ACE inhibitor will block that pathway of the RAS activation and would eventually result in the prevention of the aldosterone secretion, which would result in the sodium retention. Now, indapamide, on the other hand, would also address the sodium retention that results from hyperinsulinemia. Now, you would wonder why we have chosen indapamide, why not any other diuretic, and why indapamide? And as you can see clearly from this slide, is that indapamide is more than a diuretic. So it has two mechanisms of action, actually. About 95% of indapamide's effect is actually in the peripheral arteries, where it induces the synthesis of prostaglandin E2 for local vasodilation. So you have that vasodilatory effect. And then on top of that, you have a 5% diuretic effect at the kidney level to correct the sodium overload that we've seen earlier on. So this dual mechanism of action makes it very potent. And you can see clearly that you can't achieve this with a CCB. So definitely for you as a clinician, when it comes to blood pressure reduction, when it comes to an antihypertensive, you are definitely expecting blood pressure reduction. And for these patients with 1 tablet a day of Coversol Plus, you are looking at up to 51 millimeter mercury drop in the systolic blood pressure in 3 months and 23 millimeter mercury drop also in a month for your hypertensive patient with type 2 diabetes or even metabolic syndrome. And clearly, for these patients, we've seen that the risk of cardiovascular events is really, really heightened because the coexistence of diabetes and hypertension would increase their risk of future cardiovascular events. And for which reason your antihypertensive needs to go beyond blood pressure control. And Coversol Plus also offers you that. So that was clearly seen in the advanced trial involving about 11,000 plus hypertensive diabetic patients. And at the end of this 5-year period, with patients on this combination of perindopril and indapamide, there was a significant reduction of 18% in cardiovascular related mortality, 21% in total renal events, and as much as 65% in end-stage renal disease. So you can see that this combination is actually going beyond blood pressure control and offering your patients that additional cardiovascular and renal protection that is needed in hypertension and metabolic syndrome. So to conclude, Coversol Plus, with just a tablet a day, you're looking at an effective blood pressure reduction to bring your patient to that target BP. You're also looking at 24-hour blood pressure control, which is very, very important. And then on top of that, you have the added benefits of cardiovascular and also renal protection. So these 2 doses are currently available on our markets, and you can find them in any of the, long chain pharmacies, Top Up, Art Pharma, NS Chemist. Both strengths are equally available. And as well as outside Accra, in Kumasi, in the Volta region, it's available. So we have this at every community pharmacy. Most importantly, the top chain pharmacies. Thank you. If you have any questions, we would address them immediately. All right. So thank you very, very much for participating in today's CPD program. We hope it was insightful. And we would definitely follow up with you individually if you have any questions prior. As a result of this presentation, you can also let us know and we'll address them individually. Thank you so, so much. Have a wonderful evening.
Thank you.